Hello, I'm Elena Wilson, and I chose to do my master's project on primary hyperparathyroidism. I chose this topic because my grandmother actually has primary hyperparathyroidism, and I didn't know much about the topic, and I wanted to help her. So today we are going to talk about the background and etiology, the clinical assessment, the diagnostic workup, and treatment for primary hyperparathyroidism. The parathyroid glands are four rice grain-sized glands on the posterior aspect of the thyroid. These glands normally release parathyroid hormone in response to a low serum calcium. Primary hyperparathyroidism is when there are elevated levels of parathyroid hormone in the absence of a secondary cause. Independent risk factors for primary hyperparathyroidism include low calcium intake, decreased physical activity, the history of hypertension, the use of loop diuretics, and new research has also shown that increased waist circumference and weight are also independent risk factors. Primary hyperparathyroidism is relatively uncommon and typically affects elderly and the women. Before routine lab testing, primary hyperparathyroidism was characterized by this little saying, stones, bones, abdominal groans, and psychiatric moans, which refers to the kidney stones, osteopenia, and neuropsychiatric symptoms such as fatigue, depression, irritability, and mood swings. Now, with routine lab testing, most patients present asymptomatically. In order to be classified as asymptomatic, which is important later for treatment, the patient needs a renal ultrasound and a DEXA bone scan to rule out asymptomatic kidney stones and osteopenia. If the patient has these things, they are considered symptomatic. For lab testing, I will divide primary hyperparathyroidism into two categories, classic and mild, and explain what the lab values for each would look like. Classic primary hyperparathyroidism typically presents with hypercalcemia and an elevated parathyroid hormone. If you think about it like this, the parathyroid gland is acting up. So even when you have enough calcium, it's still releasing that parathyroid hormone, which causes even more calcium to be released, which is why you have this hypercalcemia. Mild primary hyperparathyroidism encompasses two different scenarios. Patients with persistently elevated parathyroid hormone, and persistently just means that elevated on 3 separate occasions at least 6 months apart with a normal calcium, and it also includes patients that are hypercalcemic with an inappropriately normal PTH. And I just think about it like this. If your parathyroid gland wasn't acting up and you were hypercalcemic, then your parathyroid hormone should have been low. Ultrasound is most commonly used to detect the abnormal parathyroid gland, typically because of its cost effectiveness, but was recently found to only be 72.2% effective. The technetium-99m SESTA imaging, commonly referred to as a MIBI scan, was found to only be 79.6% effective. A much more specific and sensitive test is the fluorocholine PET-CT scan, which finds 100% of the abnormal glands, especially the ectopic glands. The fluorocholine PET-CT scan uses an IV tracer that is taken up by these parathyroid adenomas. The picture shows a patient with an ectopic parathyroid gland. In images A and B obtained by the MIBI scan, they show no abnormal ectopic gland. Images C through F are of the fluorocholine PET-CT images, and the blue arrow indicates the abnormal ectopic parathyroid gland that the MIBI scan missed. So, let you see that. For symptomatic patients, the gold standard of treatment is the parathyroidectomy to remove the offending gland. For asymptomatic patients with the following criteria are also recommended to undergo a parathyroidectomy. If their serum calcium is greater than 1 milligram per deciliter, if they are osteopenic or osteoporotic, if they have a low creatinine clearance, if they have asymptomatic kidney stones, or if their 24-hour urine calcium is greater than 400 milligrams per deciliter, and if the patient is younger than 50 years old. Surgery should also be considered even when these even when asymptomatic patients don't meet these criteria, just because parathyroidectomy is the only definitive treatment. For patients unwilling or unable to undergo a parathyroidectomy, or if they are asymptomatic and didn't meet the qualifications and don't want to have surgery, medical management is used to prevent disease sequelae and manage symptoms. If the primary indication for medical management is hypercalcemia, treatment with a calcimimetic is recommended. Calcimimetics are used to lower the amount of calcium in the blood. These drugs lower but don't normalize parathyroid hormone, and it doesn't improve bone turnover, so it has no effect on the osteopenia that can be accompanied with primary hyperparathyroidism. For osteopenic patients, treatment with bisphosphonates is recommended. All patients, even surgical candidates, should be supplemented with vitamin D, and they should be treated to a vitamin D level of 30 nanograms per milliliter and to a minimum vitamin D level of 20 nanograms per milliliter. So that's just the treatment. This concludes the presentation. I hope you all learned a little something about primary hyperparathyroidism, and I appreciate your time. Thanks.